All right, let's talk about a healthcare idea that, on the surface, seems like a total no-brainer. It's a simple, common-sense policy that feels like an obvious win. But as we're about to see, when this idea was actually put into practice, it showed just how easily the best intentions can have some, well, very unexpected consequences.
I mean, just think about it for a second. You've got some minor thing going on, a pesky rash, a cold sore, maybe pink eye. Now, instead of trying to book a doctor's appointment days from now, or worse, sitting for hours in a crowded ER, you just walk into your local pharmacy. You have a quick chat with the pharmacist and walk out minutes later with the prescription you need. Sounds pretty great, right?
Well, this wasn't just a thought experiment. This exact idea was put into practice in Ontario, Canada. And it was designed to solve a problem that I think pretty much anyone, anywhere can relate to. The absolute hassle it can be to get even the most simple medical care.
Look, even in a place with universal healthcare like Canada, getting to see someone quickly can be a real challenge. You know the drill. Long waits for a family doctor, emergency rooms that are totally swamped, often with people who don't have a true emergency. All of this turns what should be a simple task like getting a prescription into a major ordeal.
So, Ontario decided to try something new. In January of 2023, they gave pharmacists the authority to prescribe medications for 13 common, pretty minor health issues. The thinking was brilliant. Let's free up doctors, take some pressure off the ERs, and get people the care they need way faster.
And you know what? At first glance, it looked like a home run, a massive, undeniable success. The initial data that came pouring in right after the policy launched was, well, it was pretty incredible. The effect was almost immediate. Practically overnight, foot traffic into pharmacies across the entire province jumped by an average of 16%. That's a huge number. It was crystal clear that people were embracing this new service in a big way. So, the story seems pretty straightforward, right? The policy was working exactly as intended. It was breaking down barriers, getting people faster care, a slam dunk for public health policy. Or so it seemed. Because this is where our story takes a really fascinating twist. When a couple of researchers, Alex Hoagland and Guan Wang, decided to look past that big, flashy 16% number, they found a much more complicated and, honestly, a much more important story about who this policy was actually helping and who it wasn't. What they uncovered was that this policy, which was supposed to help everyone equally, didn't quite work out that way. In fact, it created this sharp, totally unexpected divide between different types of communities. So they focused their research on two specific kinds of areas. On one hand, you have what they call materially deprived neighborhoods. These are places with lower average incomes, less job security, and housing challenges. And on the other hand, they looked at neighborhoods with large racialized and immigrant populations. Now, for the materially deprived communities, the policy was an incredible success. In the most deprived areas, pharmacy visits didn't just go up by that 16% average, they shot up by a staggering 25%. For these folks, the policy was a game changer. But then, they looked at the racialized and immigrant communities. And the result was absolutely stunning. Pharmacy visits didn't just stay flat, they actually dropped by 14%. A complete reversal. And that is the central mystery here. How on earth could a policy designed to make healthcare more accessible actually lead to a significant drop in access for a group that already faces so many barriers? Well, the answer was hiding in a problem that existed long before this policy was ever created. The first clue is right here in what we can call the pharmacy gap. See, there was already a huge disparity in where pharmacies were located. Non-minority areas had 2.1 pharmacies for every 1,000 residents. But in racialized and immigrant neighborhoods, that number was just 0.9. That's less than half. A massive resource deficit already baked into the system. So here's what the researchers figure happened. When this super popular new service launched, the very few pharmacies in those underserved areas got totally overwhelmed. So faced with crazy crowds and long waits, what did people do? They started driving to less crowded pharmacies in other, better-served neighborhoods. This substitution effect actually ended up draining foot traffic away from their own local pharmacies. But wait, the story doesn't even stop there. This one policy change didn't just affect where people went for a prescription for a common cold. It created a ripple effect that reshaped how people moved through the entire healthcare system. What happened was, pharmacists basically took on this powerful new role. They became the new frontline traffic directors for healthcare, triaging people and pointing them in the right direction for the right level of care.
And you can see the results of that rerouting right here. The study found a 9% drop in foot traffic to hospitals and emergency rooms. But at the very same time, visits to outpatient clinics, think family doctor offices, actually went up by 4%.
As the researchers themselves put it, pharmacists were playing this crucial role in redirecting patients away from crowded hospitals and toward more appropriate outpatient care. In other words, they weren't just a substitute for doctors, they were helping the whole system run a lot smoother by getting patients to the right place. So what's the big lesson in all of this? Well, it shows that creating real access to healthcare is about so much more than just passing a law. A great policy idea can't work if the physical resources, the pharmacies, the clinics, the staff, aren't there on the ground to support it. It's a powerful reminder that the word access can mean two completely different things from one zip code to the next.
And that brings us to the really critical question at the heart of this entire story. The policy definitely made healthcare easier for a lot of people, but in doing so, it unintentionally made access less equal for others. And that is a powerful lesson. When we're designing these big solutions, the goal can't just be to make things easier. It has to be to make them truly equal.